The topic I want to discuss today is critically important for patients going through what's usually called protracted benzodiazepine withdrawals to understand. And this stuff is so important to their outcome, and rarely do they realize it. Let's get started. Protracted benzodiazepine withdrawals. Look, I got other videos on it. It's in the description below. There's links to those, and it will be up at the end of this video. But protracted benzodiazepine withdrawals, those that are having a very difficult time coming off of benzodiazepines. We've discussed the symptoms. They're large, varied, and all over the place, and it's a nightmare to deal with for the patient, and many practitioners don't know how. I want to include in that something that we haven't really talked about much, and I don't know how much coverage there is of it out there. There is some, but let's change benzodiazepine protracted withdrawals to psychotropic protracted withdrawals. What is often not discussed is other people on central nervous system medication, SSRIs, something even like clonidine, Lyrica, gabapentin, you name it, they also suffer this kind of thing as those going through protracted benzodiazepine withdrawals. So let's call it something important for those going through psychotropic withdrawals, protracted form, with all of the varied symptoms, everything from head pressures, flashing lights, anxiety, emotional dysregulation, autonomic dysregulation, and so on. Of those group of patients, that subset of patients that are going through this, most of them are benzodiazepine. Probably the second number of these kinds of patients are SSRI and other various psychotropics. That's important. Put an exclamation mark there, because those patients are also out there, and I have all of them. Of these patients, there is a particular feature that you can attribute to these patients that they themselves don't recognize until I point it out to them, whether they've experienced it yet or not. And it is a concept I'm going to introduce. I think I may be the first one to coin this term. If you see any different, let me know. It's psychotropic hypersensitivity. Psychotropic hypersensitivity. If I enjoyed research more in publications, I'd probably go publish. If there's a smart graduate student or a medical student that wants to publish on this topic, give me a call. We'll get it done. Psychotropic hypersensitivity. What is it? When I have patients come to me, and they may come for various reasons of their withdrawal syndrome that's protracted, it might be something like, hey, I was on benzodiazepines for this short period of time. I stopped, and boom, here I am 6 months later, 1 year later, 2 years later. Whatever type of patient it is that is going through long-term chronic bizarre withdrawals that nobody buys, and they think they're doctor shopping. They're not. They're relief shopping. What happens to these patients most of the time is they develop psychotropic hypersensitivity. What is that? Here's what it is. These patients, as they go to other practitioners, and now they don't want to take the original insulting medication, whatever it was, usually benzodiazepines, they start to give them other medications to relieve their supposed symptoms from sometimes the practitioner's view, but the symptoms that they're complaining of. What ends up happening is that each drug that they're put on, they have, for lack of a better term, some sort of a hypersensitive reaction to it that messes them up more. And I don't know which thing to describe in terms of symptoms, and these are real symptoms, but they have these symptoms that are in the category of the benzodiazepine protracted withdrawals. But what's happened to them now is immediately when you start them on something else, something of that nature happens. I have one particular guy right now that just started Klonopin after dealing with protracted benzo withdrawals for a couple of years, and then had an issue somewhat with gabapentin. Someone started him on clonidine. Now he can't get off the clonidine, and he's been on it a short period of time. It causes blood pressure fluctuations and all kinds of other things. Here's what I'm trying to tell you about this issue. It is real, and sometimes patients don't really recognize it, and they are just starting to doctor shop, and some have gone down that road, and they do recognize it, and they know they just can't be put on anything, and they are fearful and traumatized to see any doctors, to start on any medications, and rightfully so. This is particularly stands out when that poor patient is suffering from chronic akathisia, secondary maybe to the first insult, the second drug insult, the third drug insult, whatever. Now we're dealing also with chronic akathisia. I have a good handful of these patients at any one time, and it keeps growing, and they're extremely difficult to treat and manage. Now, what happens with this group of patients, and if the practitioners aren't aware of this, I want you to be aware of it so you're cautious on how you engage with us, the deadly doctors, okay? The medical system, okay? You, at the very least, should be aware that no, you can't just try any medication for sleep, for mood, for anxiety, okay? You just can't, because now and for the rest of your life, you may be this thing that I'm calling psychotropic hypersensitive. Again, I don't think there's much data on this, and I want to be upfront about this, right? But, you know, there's certainly a large amount of anecdotal evidence, at least in my practice over the last few years. They're difficult to treat because what you really want to do is be hands off in a particular sense, and this is for the practitioners out there. Stop trying different medications on them. Hands off. Look for that window of stability with whatever they're on. Or if you really are well versed in your arsenal of medication, be very proactive, hands-on, and supportive of initiating a particular medication that you believe will help them in the short run and long run. Let me give a particular example of this. You know, one of these patients is maybe suffering from chronic akathisia, right? And then, you know, with that comes all sorts of other things. And I have to do a video on chronic akathisia because I don't think most practitioners understand it, and I don't know where many patients are that. It's not just, it's much more than feeling restless inside or needing to move. It's a nightmare scenario, and people often want to just take themselves out. It's just dysphoric nightmare, okay? Now, when you know, I may have a patient like that, and there's other medications involved, and we're trying to kind of manage that. I don't want to just willy-nilly guess and put them on something, but sometimes there might be something for that particular patient that I have gained full clinical confidence and the courage of my convictions to move forward with, because I know it's going to help them. And sometimes I know that this is about us buying time and me giving them a lot of professional, emotional, clinical support. Somebody's time might be 6 months. I'm sorry, but somebody's other person's time might be 6 years, 2 years, 3 years. But positive changes happen. The nuance art of the medical management is not to put anything on that might trigger worse things, and those few medications that you think may help, because they are really traumatized from medications, you start that, follow them closely, and even if they tell you it's not doing anything, you're thinking, man, that's a good thing it's not doing anything, because remember, when you came in here, someone put you on GABA and within 2 weeks you were dysregulated in a nightmare situation. It is doing something. Bump up the dose and keep on it, and you follow them closely. Psychotropic hypersensitivity. It's one for whatever reason the trigger was, usually initially some psychotropic medication, Lyrica, benzodiazepines, SSRI. They're usually going through protracted withdrawals. Not always. Maybe it was just triggered by some medication, and now they're hypersensitive and they have to be made aware of this. And then you, as the practitioner, has to manage it and take the few medications that you think will be beneficial, be emotionally supportive, get them on it, and walk them through until they get to the other side. And, you know, the question is always raised, what is the mechanism of this? And was the original medication the original insult? I actually personally don't believe that what would be considered causation in the clinical and scientific term applies to this. This is a very complex set of events: genetic predisposition, childhood development, traumas in their life, interaction between the being and their environment. This is where they're at. I don't care. There's not enough data, and I'm not looking for that as far as the mechanisms, but I certainly have gained enough information and experience, even from anecdote, and that includes all of the patients I've seen, to be able to clinically manage this. Not always perfectly, and sometimes the patients get disappointed because they're not moving forward as they should, and many respond immediately in various mechanisms, whether it's getting him back in a controlled way on the original medication and describing the risk versus the benefits, or the few medications that I have discovered through eliciting the history or my knowledge about that condition that I think will help them. And sometimes it does in the short run, and sometimes in the long run. In medicine, first, do no harm. 2, relieve pain and suffering. 3, every action you take, small or large, consider the benefit versus the risk. And sometimes you just have to be there as a listening, compassionate, empathetic ear for that patient, for them to make it through that day, that week, that month, that year. I hope this helped. I think this is one of the more important videos I've done. If you do know something, a clinical syndrome that is akin to psychotropic hypersensitivity, drop it in the comments below. Otherwise, like, subscribe, hit that bell. See you guys next time. Peace.